Hello, everyone. My name is Gabrielle Altit. I'm a neonatologist. I'm based at the Montreal Children's Hospital, and I run the neocardiolab.com website. And today we'll go over the case of September 2025, which is on functional pulmonary valvular stenosis or atresia in a premature infant. And so first I want to mention that the neocardiolab.com website has been supported by an unrestricted educational grant by Malincrot, for which we're very grateful and thankful, allowing us to provide educational content regarding neonatal hemodynamics. I also want to mention that today case review will be going over some of the echoes. So this is the first part of this case review. And exactly as we would do in the context of case review within our neonatal hemodynamics training program. I do want to mention that a lot of the therapies, medications, and interventions that we use in the context of neonatal hemodynamics are obviously based on precision medicine and based on the underlying physiology, which is quite dynamic and can evolve with time. But a lot of these therapies, unfortunately, have not been tested in the context of randomized controlled trials. And of course, we will need to advance the field and the science by increasing the number of trials that are tailored to the particular physiology that we're trying to address in order to understand the best interventions for our patient populations. But all in all, you will see that through this case, the physiology of some of these very vulnerable infants can be quite dynamic. And sometimes we do face, very repetitive patterns in some of the patient population that we see, but sometimes we need to think outside of the box and getting more information and digging into the physiology can help us better tailor the therapies for these patients. So this is the case of a 25 weeks patient with severe intrauterine growth restriction and a birth weight of 550 grams. The antenatal course was remarkable for prolonged rupture of membrane beginning at 16 weeks, which obviously brought the concern of pulmonary hypoplasia as the liquid did not reaccumulate. And so at birth, the patient developed profound hypoxic rest failure. The patient was intubated in the delivery room, did receive surfactant, but despite these measures, remained with, poorly oxygenated in the first few hours of life. The patient was placed on high frequency oscillation with mean airway pressure that was climbed up to 16. And the HFOV was administered using volume guarantee at 2.5 cc per kilo. Despite that, the patient remained with 100% oxygen exposure in the first few hours of life, with saturation fluctuating around 75% and no differential of SAT being observed. And so at that point, the clinical impression of the team was hypoxic respiratory failure with a component of acute pulmonary hypertension. And so because of these contexts and the attempt to maximize ventilation and support and the failure in oxygenation, the team decided to initiate inhaled nitric oxide at 10 parts per million, but with only some transient improvement in oxygenation and eventually escalation to 20 ppm with no further benefit. This is very inherent to our protocol of where we start premature infants on lower dose INO. If we do end up with INO in these patients, knowing that there's really no great evidence for inhaled nitric oxide in these patients. If it is to prevent BPD, for sure there's no evidence. There actually is even signals for harm in some of the trials. But for acute pulmonary hypertension physiology, there are some observational studies pointing out that some of these patients can respond, to INO and sometimes even to lower dose INO because their pulmonary vasculature tends to be very sensitive to pulmonary vasodilators. Back to our case, there was still persistent respiratory acidosis despite trying to optimize ventilation with a CO2 of 84. The blood pressure at the time of evaluation was 35/17 with a mean of 22, mean arterial pressure, and that was obtained via an umbilical arterial line. And then the baby was not thought to be tachycardic with a heart rate around 5160 and a temperature that was at 36.2. Lactate levels at the time of assessment were reassuring. Essential umbilical venous line was placed. an arterial line actually was not successful. So this was by the cuff. Sorry about that. And a radiography did show some bell-shaped thorax with reduced lung volume, consistent with some degree of pulmonary hypoplasia. And so, given the hypoxic rest failure, we were asked to evaluate this patient by TNE. So we'll go over the first clip. So this will be the first case review. This is parasternal long axis view, where we see that the mitral valve is opening and closing. We can appreciate the left atrium here. We appreciate the LVOT that doesn't look crowded, with an aortic valve that opens and closes. We see the ascending aorta here, and we see the left ventricle. The subjective function of the left ventricle seems to be adequate at the time of assessment. We can see here that we do a little sweep where we see more of the body of the left ventricle and eventually going towards the right ventricular outflow tract. Well, we see the thin pulmonary valve. And then when we put color and go towards the posterior side, we start seeing the RV inflow, where we see some significant degree of tricuspid insufficiency. But I always want you to pay attention to the Nyquist, which is relatively low in this case. So we see some TR here. We'll be able to calculate it a bit later. So here we're shifting to our tripod view, where we start seeing the branch PA that looks of adequate caliber, and we start seeing also the ductus arteriosus, which is the third limb of this tripod view. And then here we see a bit of the RV outflow tract, and already we can feel there's some concern about the fact that we don't see the pulmonary valve opening as nicely as we would like. This will be more objectified a bit later. We then go and do a sweep towards the left ventricle. We see the mitral valve. We see that there's no significant hypertrophy of this left ventricle. We see the papillary muscle and good contraction of the LV, with potentially a bit of flattening of the septum at the peak of systole in this case. And we can see that the RV underlying is there, but doesn't look dilated, at least relative to the left ventricle. Here I've put a still frame to show you that at times the pulmonary valve does open. So these are two still frames showing that there's definitely some opening of the pulmonary valve. Sorry, this is the pulmonary valve. And so there is some opening with continuity with the outflow tract. We then scan the septum at a low Nyquist or low velocity filter to see if we can see any kind of VSD. That's more for my friends in cardiology who evaluate structural, but also sometimes a VSD can inform you on the hemodynamics of these patients. When we get to more of the base of the heart, we can see that again, we have signs of this tricuspid insufficiency as we start seeing the tricuspid valve in the short axis view. So then we put color over our tripod view here with a low Nyquist at 0.43. This is at a higher Nyquist, where we can see that this duct is completely left to right, so it's red. It is of low velocity. So here we've done what we call the pulse wave Doppler, and we can see that it is red with maybe, some signs of artifacts from the high frequency oscillation here, and then back again left to right, high frequency, left to right. So it's briefly left to right, and then probably during diastole, the velocity are so low that they're near zero. So there's a rapid equalization across this duct. And this is a CW confirming that the velocities are very low, mostly left to right, maybe a brief right to left here. So then we're looking at the branch PA at a very low Nyquist, and we do see that there's flow through the branch PAs. We can see kind of the course of the duct in the background by color. And I don't know if you can appreciate, despite the very low Nyquist at 0.43, we can only see via the pulmonary valve some trace pulmonary insufficiency. So this is this red little flame, and we barely see any blue coming through the valve. So we don't see any blood flow being generated actually by the right ventricle forward. We see blood flow probably coming from the duct, swirling into the pulmonary artery and providing blood flow in the MPA, RPA here, and then LPA eventually. As we angulate down, we can kind of appreciate that the interatrial membrane is actually shifting from the right side to the left side, bulging into the left-sided cavity. We're going to see that more later. This is a four-chamber view where we could see that the RV has a relatively good longitudinal contraction of the tricuspid valve. We can again appreciate the interatrial septum being aneurysmal and actually shifting from the right side to the left side. And that's probably because of the shunting at the atrial level. When we look at the color box over the four chamber, we see that there is flow from the mitral valve into the left ventricle, which looks like it's filling appropriately. But here you can see the severe tricuspid insufficiency that is actually going to the roof of the right atrium and stretching your interatrial septum from the right atrium to the left atrium. We can appreciate it better here, where you see this flow from the right ventricle being generated towards the right atrium and eventually crossing to the left atrium. So here we obtained TR. We'll get some measurements very soon. This is the TAPSE. This was measured to be slightly diminished in the context of this patient. I want to remind you that a right ventricle who pumps its output towards the right atrium will not face a huge afterload if there's a lot of TR, because obviously as the RV is pumping, if a large fraction of its ejection fraction goes backward, it's pumping against a low resistance atrium, and so its function may look as preserved, but that's because it's pumping against the low afterload of the right atrium, and that's secondary to the significant tricuspid insufficiency. Here we see the two-chamber view. Again, we can appreciate that the left ventricular function looks adequate. And then here we're starting to look at our what we call RV3 chamber view or TED view, where we have the inflow portion, the RV body, and eventually the pulmonary artery with the pulmonary valve. We can appreciate again by color that there's significant TR. In the subcostal view, we have again the interatrial septum that is aneurysmal and bulging towards the left atrium. That indicates that the RA pressure is likely elevated, or this is secondary to the significant TR. We can appreciate how this TR is going from the RA and then bulging towards the LA through the interatrial septum, providing a huge volume of hypoxic blood, shunting right to left into the atrium and explaining why some of these patients may be quite blue or desaturated. So here now we obtain the TR as we're well aligned, knowing that this is significant TR, and with the shifting of the septum, we know that the RA pressure is likely to be relatively high, probably a bit more than 5 millimeters of mercury. And so if we have a TR with a peak velocity of 2 meters per second, that gives us at least 16 / even a bit more than 16, because we can see here it might be around 2.1 meters per second. So we're around 16 to 20 of right ventricular to right atrial gradient, plus the 5 to 6 RV pressure. We're around the 25 millimeters of mercury of RV systolic pressure. Now, the problem is that if our pulmonary valve is not opening, the RV systolic pressure won't equalize with the pulmonary artery pressure. And so the TR is not a reflection of the actual pulmonary arterial pressure. We also know that our PDA is wide open with low velocity, which informs us that it is completely unrestrictive. And because it is unrestrictive, obviously the pulmonary artery is connected to your aorta via a big duct. And so the pressure across that duct will rapidly equalize because there's pressure transmission. It's like connecting two boxes via a big tube. Pressure one will be equal to pressure number two if you connect both of them. And knowing that the systolic blood pressure at the time of the echo was around 35 millimeters of mercury, that tells us that the peer pressure will also be around 35 millimeters of mercury. And so we see here that your RV systolic pressure is 25, and so clearly under what's happening into the pulmonary artery. And so hence not surprising that the RV is not able to generate the necessary flow to open the pulmonary valve. So here we're obtaining a Doppler in one of the pulmonary veins, and we can see that, these velocities are very low, and that's probably because the pulmonary blood flow is relatively low in this patient. And we can almost appreciate the fluctuation by the high frequency oscillation, which may be actually, impacting the pulmonary blood flow and eventually the pulmonary venous return. We see, this is again another view of the TR, which confirms the measurement that we had. In this view, we see the coronary sinus, we see our right atrium, left atrium, and we see that the pulse wave Doppler is again trying to capture a pulmonary venous flow. It is important in patients who have strict right to left shunting at the atrial level to rule out total anomalous pulmonary venous return, because in TAPVR you have an obligatory right to left shunt. So as soon as you see a strict right to left shunt at the atrial level, that's one of the first diagnoses you want to rule out. And we will see that in this particular patient, we see all the pulmonary veins. So again, we see here the interatrial shunt that's right to left, eventually leading to blood flow being hypoxic, entering the systemic circulation. We can appreciate that the coronary sinus is draining into the right atrium here, and we can appreciate the significant TR. As we go forward, we see the LV outflow tract that seems unobstructed. We can see it here as well in this subcostal view, and we can see that the RV body is connected to our pulmonary artery. So in a blue baby, you also want to make sure that you rule out transposition physiology. And so in subcostal, that's an important thing to look at. So 95% of transposition will have parallel great vessel. And of course, here we see that the right ventricle is actually giving a great vessel that is branching out into the pulmonary artery. So we've ruled out that this is TAPVR. We ruled out that this is TGA. And now we're looking at the RV outflow tract to better understand and make sure there's no actual RVOT obstruction that is congenital. So like pulmonary stenosis or any kind of RVOT obstruction like pulmonary atresia or supravalvular or infravalvular stenosis of the RVOT. So these are things that you obviously want to check and make sure, and your cardiologist should be involved in all of these cases to rule out any kind of congenital heart defects. So here we're doing a Doppler in the LVOT. We see that there's actually forward flow through the aortic valve, although these velocities are low, telling us that there might be some impaired output in this particular patient. And when we're trying, although we see that the valve has open in this view, we're obtaining a pulse wave Doppler. We see that there's almost no velocities. There's almost no antegrade blood flow from the RV to the PA. So I'm going back to show a few Dopplers that we obtained that we see almost no flow anterograde. Again, here, similar no flow anterograde or almost none. When we actually put 2D, we see that pulmonary valve here. We see that it's thin-walled, and we can see the trace red flow through it, which tells us that there is definitely some degree of pulmonary insufficiency, but we don't see much of the flow being generated from the RVOT through the pulmonary valve, opening the pulmonary valve and going into the PA. We can see this red jet at some point that is from the PDA. And when we do a zoom, you can appreciate how this valve is actually moving in space, like almost dancing up and down, being tethered by the RVOT, but really not much opening. And by color, we again at least at this Nyquist, don't see much of the blood flow, probably because if there is any kind of blood flow going through, it is at a very low velocity. And we've seen that from the Doppler, where if there is something going through, it is at velocities that are extremely low. We do see the pulmonary insufficiency from the little red jet coming back into from the PA to the RV. So here, we're again putting some color box on our RVOT, seeing that the blood flow feeding into the pulmonary artery is actually being fed by the duct. So we see this red flow then swirling into the pulmonary artery. So the red flow swirling into the pulmonary artery. And when we do a CW, we can see that there's really limited negative blood flow. So if you remember, this is a subcostal view. RV is here towards the RVOT. In the middle, we see the aortic valve. Here, we're trying to obtain a CW through the pulmonary valve, which is here. Whatever is coming towards the probe is supposed to be blue. Whatever is coming towards the probe is supposed to be red. That's why this PDA is red, because it's coming from the aorta towards the pulmonary artery. That's why this pulmonary insufficiency is red, because it's coming from the PA towards the RV through the pulmonary valve. So whatever is going to be red is by convention a positive velocity, so above the line, and whatever is blue is going to be negative velocity. So here we see that there's a little blip of negative, and then you can see this red, which is actually pulmonary insufficiency, and then a blip of negative, and again a bit of red, which is pulmonary insufficiency. So here we've shown that at a Nyquist of 1.02 meters per second, we almost see no blood flow into the branch pulmonary arteries. But when we start dropping our Nyquist to 0.38, so you can see it live from 1.02 to 0.38, that's when we see that there's this low velocity blood flow inside the branch PA that is being generated by the duct feeding into our pulmonary arteries. We then did Dopplers into these two pulmonary arteries. So here we have the LPA, pulse wave Doppler, exemplified by the two lines, where you can see that there is this very limited velocity into the left pulmonary artery. And then same thing, very limited velocity into this right pulmonary artery with a rapid positive deflection in systole, and then, rapidly going back to the baseline. You can see that the velocities here are very low at 50 centimeters per second. And so this patient, despite being fed by the PDA, you can see that there's likely downstream some very high pulmonary vascular resistances relative to the situation. And that might be driven by various factors. There could be a component of pulmonary hyperplasia. There could be a component of acidosis, the hypoxia. All these elements can contribute to the pulmonary vascular resistance being very high. The branch PA are a good caliber, so it's always important to make sure that these patients don't have pulmonary vascular hypoplasia, at least in the larger arteries. Here you can see that in order to visualize pulmonary venous flow, we need to drop our Nyquist quite low at 0.17. So we see one pulmonary vein here, another pulmonary vein here, a blue flow that's coming here, and another flow that's coming here. So we have 4 pulmonary veins, at least by color, that are draining into our left atrium. And then when we Doppler, we see this another crab view that shows these pulmonary veins. So 1, 2, 3, and then the 4th one is here. And then we can see that as we obtain pulse wave Doppler, we see these very rapid these very narrow peaks of systolic and diastolic velocity in the pulmonary veins that are likely related to part of it, the artifacts of high frequency oscillation. So then we were obviously querying our RVOT. So that's another view outlining as we drop significantly the Nyquist, that there's not much antegrade flow through the pulmonary valve. We also look at 2D. We've shown in still frame that it is able to open, but obviously a large part of the fraction of the ejection fraction of the RV is actually going backward into the right atrium. Here again, the tricuspid insufficiency. So you have RV, septum, LV, right atrium, left atrium, and then this blue jet is the tricuspid insufficiency. Subcostal view, finalizing, the visualization from the IVC, so the situs going into the RA, and then doing a little sweep in our subcostal. So here we're looking at our arch view to make sure there's no signs of obstruction. We see that there's nice blood flow, and this time you see our Nyquist is 1.02 meters per second, so there's relatively good velocity into the arch. And then when we look at the Doppler within the arch, we see nice forward flow. So the blue meaning it's going away from the probe, so the arch is like this and going away from the probe. So what did we conclude in this context? We saw that the PDA is left to right and unrestricted, allowing pressure equalization across it from the aorta to the PA. And so although it is left to right, we see that it's a very low velocity, telling us that there might be some component of PVR that are near the SVR. But also outlining that this PDA is really dependent for the pulmonary circulation. The PFO is completely right to left with bulging of the interatrial septum, which is almost aneurysmal from the right to the left atrium. There was significant TR, knowing that there was some degree of right to left shunting. Well, there was a strict right to left interatrial shunt, and there was the flow of the TR reaching the roof of the right atrium. There was almost no output coming out from the RV antegrade, and all the flow in the PA are from the PDA that was left to right. The RV function was felt to be decreased, and of course, if your RV is not able to generate forward flow, you should always be concerned that the inherent inotropy may be to some degree impacted, and the RV afterload, as well as the chronic, the acute increase in afterload of the RV in this particular patient who may have had some degree of distress from the perinatal transition, and also with the context of ruptured membrane for many weeks, plus the prematurity, may have impacted this RV adaptation. We see that the LV function was within normal limit. Actually, our ejection fraction calculated was around 60%, but we did have decreased LVOT VTI with decreased LV output despite that. Knowing also that portion of the output eventually gets stolen from the aorta and feeding into the pulmonary arteries via the duct. The pulmonary valve does open and close, but there's almost no anterograde flow seen. The pulmonary veins were seen and were draining to the LA bicolor and by 2D. But of course, on HiFi, there was some artifactual changes to the Dopplers. And we didn't see any big IVH in this particular patient, knowing that this patient was currently on INO with a left to right PDA. So typically when you have a left to right PDA, you do not want to maintain INO in premature babies because you want to be, you may have a component of RV output that's going towards the pulmonary branches, and on top of it, you get excess pulmonary blood flow from your aorta to your PA. And so in these patients, you have already increased QPQS, but that's if your RV is generating forward flow through the pulmonary vasculature, and that your PFO is either completely left to right or bidirectional and mostly left to right. So in these particular patients with left to right PFO, left to right PDA, of course, you have increased QPQS, and you don't want to increase further your QPQS by giving oxygen, low CO2, INO. That could submit these patients to pulmonary edema, to systemic steal, to pulmonary hemorrhages. So these are things that you want to definitely avoid to give INO in these situations. But in this particular case, where we have no contribution of the RV to forward flow into the pulmonary artery, and that you're dependent on your PDA to feed your pulmonary vasculature, you want to maintain low PVR to be able to sustain blood flow into your pulmonary circulation, but also to try to rescue the RV who's been maladapting in the postnatal transition and who's now struggling to generate forward flow. So in this context, our decision was made to, first of all, maintain low PVR by maintaining INO as a pulmonary vasodilator, to provide some inotropic support. Knowing that our heart rate was 150, we decided to opt for dobutamine. If the heart rate was much more increased, we would have considered another agent because dobutamine can quite rapidly increase the chronotropy. So you always have to be careful about that. And so these were our first two steps for the management of this patient. And the other thing that we've done acutely is that we drop the mean airway pressure. The mean airway pressure can be quite significant. It can have quite a significant impact on cardiorespiratory interactions. And so in this particular patient, the mean was already 16, which can put a huge afterload on the RV, increase the intraalveolar pressure, and basically squish the vessels in your alveolar wall. So it may increase the afterload to the right ventricle, and then it could also impair the venous return into the left atrium. So it could contribute to this right to left shunting at the atrial level by, first of all, decreasing the preload of the LA, which decreases the preload of your LV and decreases your output from your LV, which we felt was partially explaining why our LVO was limited. And then the secondary thing is that, at some point, because of this right to left shunting at the interatrial level, no matter how much you're going to increase your mean airway pressure, that's not going to address the underlying extrapulmonary right to left shunting. So what did we do? We said that, of course, we need a formal anatomical assessment by cardiology. This is a physiology of functional pulmonary valve stenosis. I called it stenosis because we do see, very occasionally opening of the pulmonary valve, and we see the pulmonary insufficiency happening through that valve. Versus when we say functional pulmonary atresia, we don't see the opening of the pulmonary valve. And sometimes it can be quite challenging to actually discriminate between a functional and true pulmonary atresia. And that's where, of course, our cardiologists need to be involved as soon as possible to evaluate for structural change. But as soon as you see even a minute fraction of moment, a nice opening of your pulmonary valve, you've ruled out that there's an anatomical pulmonary atresia. These patients also have significant TR, as I mentioned. So we said this is from very low RV output and significant TR. The baby is very blue because there is right to left shunt at the atrial level. So we've switched the patient to jet at that time, and we dropped the mean airway pressure to protect the lungs, but also to drop the RV afterload. And we decreased at that point oxygen up to 40% because our patient was less desaturated. We started dobutamine at 5 and increased up to 7 as we were monitoring the response of the RV and the RV output. We kept the INO to support the pulmonary vasculature and increase LA pressure by increasing pulmonary venous return to diminish the right to left shunting at the atrial level. Since then, the patient was satting in the 90-95 with a VO2 of 40%, reminding you that an hour before he was satting at 75. The baby with a VO2 around 40%, with a VO2 around 100%. The gas at that point had normalized, and the chest X-ray was more open with more chest seen on the jet ventilator. With at that point the PEEP being 7, mean being generated between 10 and 11. Which obviously at a map of 16 was creating a lot of afterload for the right ventricle. So that's pretty much how we saw this first echo. But obviously you will see that as we went along, we monitored this patient very, very frequently because in the context of a left to right PDA with a premature infant, you want to be very careful that the physiology will not reverse because if suddenly your PDA is left to right and suddenly your RV now contributes to RV output and you get your QPQS going from somewhere like 0.5 to 0.7 to 1 to eventually a higher than 1, that's when you want to peel off all of these pulmonary vasodilator because you can steal from the brain, steal from the systemic circulation, overwhelm your pulmonary vasculature with too much pulmonary blood flow, which can lead into bursting of the pulmonary vessels and pulmonary hemorrhage. So in these patients, you want to be quite astute to monitoring the dynamic response and eventually weaning your pulmonary vasodilators. So we will see the next few echoes as we're going through the case of the month, and we'll review echo number 2 in the next video. Thank you for your attention, and I welcome comments and questions um, that you may have. I always am very open to any kind of ideas or corrections, even. And so it's always very pleasurable to engage with the community. And so please, 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 if you have any questions, comments, feel free to put them in the YouTube video comment box. Or you can even send me a private message. My contact information is always at the bottom.